Today's program is on global mental health. Here to moderate and introduce our speakers is Larry Chimerine. Larry is the former board president for ICWA and has continued to stay involved with our organization. So with that, Larry, I'll just turn it over to you.
Thank you, Ray, and welcome to everyone joining us today from literally around the world. It's great to see some old faces, old friends haven't seen for a long time, certainly since the pandemic has curtailed our traveling a little bit. I want to thank you, Ray, and the Indiana Council on World Affairs for inviting me to organize and moderate this session. It's a topic that I feel very strongly about and been involved in for quite some time. So today we'd like to focus on mental health and mental health care in the United States and how that compares with other parts of the world. We're going to discuss several aspects of mental health in a post-pandemic world and talk about what it might take to launch a global mental health moonshot. That is to really get serious about addressing mental illness in a manner commensurate with their burden on consumers, on their caregivers, the healthcare system, and really society at large. We have an extraordinary panel of experts coming to us live from England, Switzerland, India, and right here in Indiana. So I'd like to briefly introduce our panel, and you'll have already read a bit about them from the invitation. So first, Professor Norman Sartorius is the president of the Association for the Improvement of Mental Health Programs in Geneva, Switzerland. He was previously the founding director of the Mental Health Division of the World Health Organization and has served as the president of the World Psychiatric Association and of the European Psychiatric Association. And welcome, Professor Sartorius, coming us today from Geneva.
Something happened to my video. I cannot get into the picture anymore. It says the host doesn't let you show his face. So maybe you can intervene and
maybe we can sort that out while I'm introducing the others.
But I'm here listening.
Yeah. Well, next we have Professor Santosh Chaturvedi. He's a consultant psychiatrist in Vrindavan, India. He's the former dean and senior professor of psychiatry at the National Institute of Mental Health and Neuroscience in Bangalore, India. And he's editor-in-chief of the Journal of Psychosocial Rehabilitation and Mental Health. Welcome, Professor Chaturvedi from Bangalore, India today.
Thank you.
Santosh, you there?
I'm glad to be.
Great. Professor Gabby Bajaro is Secretary General of the World Federation for Mental Health, and he's president of the World Dignity Project. Gabby is an international leader in primary care mental health and integrated care and is visiting professor of population mental health at Nova University in Lisbon, Portugal. Welcome, Professor Bajaro, coming us today from London.
Thank you, Larry. Thank you very much.
Nice to see you. And Dr. Jay Chaudhry is Senior Fellow for Mental Health and Wellness at the Sagamore Institute, which is an Indiana-based research think tank. He previously served for 5 years as Director of the Indiana Division of Mental Health and Addiction and as Chair of the Indiana Behavioral Health Commission. Welcome, Dr. Chaudhry, who is here along with me in Indianapolis.
Thanks, Larry. I think you promoted me. I'm not a doctor.
Well, you're a doctor of jurisprudence, right?
Yes. Yeah.
Yes.
Promoted me. I don't know if that's accurate.
Well, okay. Well, mental illnesses are common in the United States and around the world. And the National Institute of Mental Health estimates that more than 1 in 5 U.S. adults live with a mental illness. But mental illness includes many different conditions that vary in degree of severity. On occasions, we're all sad, we're anxious, we're agitated, but these symptoms at the extreme end of the spectrum might completely dominate another person's life and totally incapacitate them. Well, we experience them and slough them off. It's just, we're not mentally ill, but they're just symptoms. But we all know people struggling to deal with one or more of these disorders, so we recognize the critical importance of addressing mental health issues because of the huge burden of disability they cause over a lifetime for the persons themselves, as well as for those who care for them and the community at large. So today we want to name some of these disorders, look at their prevalence and whether they're increasing. We want to explore why this might be happening and ask how our experiences here in the US compare with those in other countries, and even explore what we might learn from the experiences of others around the world to improve care and outcomes for these folks. So, Jay Chaudhry, you served 5 years as director of the Indiana Division of Mental Health and Addiction. Can you help us frame this issue and give us some coherent strategy for our discussion and tell us why you think this is an issue that's worth our attention and even more so the attention of public health services and society at large?
Yeah, thanks, Larry, and good morning or evening or afternoon to everybody. So I think one of the reasons and one of the biggest challenges during my time at the state was when we talk about mental health. I think it's pretty fair to say we're talking about three different things. Now, there's no bright lines between these three things, but I think it's important to frame this conversation, around these three topics. At least in the United States, I would defer to my co-panelists about the appropriate framing for the rest of the globe. But the first would be folks with severe mental illness. So this is, people who have, diagnoses like schizophrenia with psychotic features or bipolar disorder, like the people that in the United States historically lived, a long time ago, or for a long time, lived most of their lives in state-run asylums. That were famously shut down starting in the 1950s and 60s by President Kennedy, accelerated by President Reagan, and are still, I think, traditionally considered to be the responsibility of the state governments here in Indiana. And these are people who probably are never gonna work full time, and are always gonna sort of need some sort of intervention with the state. So that's one category. The second category is the people with mood disorders, anxiety, depression, sometimes called the worried well, although I don't really like that phrase because some of them are more than just worried, and a lot of them are not doing very well. And this group, I think there's been a lot of attention in the United States to the second group as a consequence of the pandemic, when we all, I think, some of us for the first time, some of us for the first time experienced such a massive disruption that caused increasing anxiety, depression, disconnection, isolation. And so, when we came out of the pandemic with a lot of energy to do something about mental health, I think this is what most people had in mind. Like, we need to do something to help people get access to quality care for primarily things like increasing anxiety and depression. And this system, I think, it's probably fair to call it just kind of a marginalized part of the traditional healthcare system, medical system. Utilizing, I think, some of the same structures, whether it's reimbursement or payers or systems, but one that was fairly ignored for a long time, and consequently, I think is suffering from decades of neglect and underfunding, and needs to be kind of brought into a place where it can meet the need. And then I think the third thing we talk about when we talk about mental health is just kind of overall mental health and well-being, like wellness, things like our level of social connections, our how isolated are we. There was just a huge cover story in the Atlantic this week talking about this is the century of solitude, the 21st century, and I think that is and the outgoing U.S. Surgeon General Vivek Murthy also has talked about loneliness as an epidemic, and I think when we talk about mental health, which is a really catch-all term, we really talk about all three of these things with the same term. And I think it's important to deconstruct that a little bit. So that, I think, is a useful framing, at least from a U.S. perspective. And your second question is a really big one and a good one, which is, why should we care, right? Why should we pay attention? Why is this important? And I think all of my co-panelists will share different perspectives and dimensions. I mean, I think the truth is that, fiscally, morally, spiritually, this is one of the issues of our time that has such a huge impact and burden on everything else, right? Which I think speaks for itself in terms of why we should care. I think that the last thing I'll say is that, somewhat optimistically, I think that there are things that work to improve mental health at the individual, community, and population health level, and I think we'll all be served if we can kind of acknowledge, learn about, and implement those things.
Great, thanks, Jay. So, Santosh Chaturvedi, from your perspective then, when we talk about major mental illness, what exactly are we talking about, and what's the relative prevalence of these disorders that you've seen?
Thank you, Larry, and thank you, Jay, for setting the ball rolling. Well, there is a bit of an issue about the nomenclature, and Jay referred to certain mental illness as severe mental illness, but it's only the name which is severe. We should not go by the severity of that, because there are a lot of other anxiety and depression and neurotic disorders which might be much more severe. And on the other hand, people might be having bipolar disorder, which might be a soft bipolar disorder. They might be having schizophrenia, which might be mild or residual. So it's time that we, probably altered the names. And the same way is about major, and it's in the name. Major is again refers to the severity. On an average, I think the severe mental disorders, by which I mean the psychotic disorders like schizophrenia and bipolar disorder, paranoid psychosis, and drug-related psychosis, these are about 1% or less than 1% of the general population. And if it in the US, it is 1 in 5 have mental illness. In India, it is 1 in 6 who have mental illness. Many times, Larry, as you had questioned, whether mental illness is increasing or not. It might not be the number, but it is a type of disorders and type of presentations which are changing. Like for example, what was hysteria and in the 50s and 60s, later on became dissociative disorders. And in many countries, you don't see them. There are certain dissociative disorders which are more common in the US, like the multiple personality disorders, but it doesn't exist in India. And we have a different type of dissociative disorders like trance state, possession state, pseudo seizures. Same way, the presentation of depression, it might have changed. For example, in some parts of the world, it's by affective symptoms, expressing sadness. But whereas in many other traditional societies like India, Asian and African, it is more of somatic symptoms in depression. So we did a study to see whether the prevalence has actually changed. Now, for example, after the COVID has gone, after the pandemic, now we are having newer disorders related to the internet, to the social media, to the use of phones and pads and things like those. So newer disorders have come in, and we'll talk about that in more detail after some time. Thank you.
Yeah, good. Yes, thanks very much, Santosh. Gabby, you're focused in a primary care practice. And from your perspective, do you believe that the prevalence of any mental disorders is increasing, or perhaps we're just getting better at diagnosing them?
Thank you, Larry, and thank you, members of the panel. A couple of things. I think the two statements are correct. So let me start by saying that, So first of all, we have become better in diagnosis, and people are also beginning to trust us to come forward to present. So of course, so if you speak to more people present, you will see an increase. So that's one thing. So the other one, of course, is that, that are they stable? Some of them are stable over time. So when I was preparing for this discussion, I was thinking when I started my training in Nigeria in psychiatry, at that time, one of the things we studied was what looked at was in the international pilot study on schizophrenia, putting almost materials later on, from WHO. And really what it showed us at that time was that the prevalence of schizophrenia, if you standardize the question and you use the same methodology, they're very similar in most part of the world. However, if you came from India or Africa, particularly Ibadan, where one of the studies took place, that people got better, faster and recover better. So therefore, if you survey, you may find out that maybe the prevalence may be lower at that time because people have recovered. So really, so have both. So really, so one of the kind of things I'm hoping we want to begin to develop is kind of a global pathway that we can all buy in, that people can ensure that they get good treatment, appropriate treatment, rather than the current system. That, Satosh said something about changing diagnosis. And I think, again, that's correct, because we need to find a better definition for illnesses that we're using so that we can compare apple with apple. So again, I go back to the traditional pilot studies that Norman Co led on many years ago. One of the things they showed was that if you train people well, they people could actually, the diagnosis was very similar. So really, so there are many things we could look into. And I want us to see how we can evolve this, over this series of discussion, and perhaps come up with something at the end that can be useful takeaway for all of us, because in this meeting today, there are people all over the world, so there could be something common to all of us that we can take and say, look, this is tangible, and this is something we can work on together. So I think I will stop here, and hopefully we can develop this thinking together at the concept.
Good, thanks, Gabby. Let me just check, because we seem to have lost Norman's picture. Norman, are you back on? Earth to Geneva.
I'm here. I can see you all, and but I cannot. I do not know what to do. I cut myself out and came back in. It says the host doesn't want me. So anyway.
Okay. Well, we can see your picture, and we can hear you. So I think that's 2 out of 3 isn't bad. So I say that a recent report indicated that there was a significant uptick in homicidal behavior during the early parts of the pandemic, when people were isolated and out of school and out of work, especially lower income people. So Norman, I wanted to ask you, we know that one devastating symptom of mental disorders is suicidality and suicidal ideation, but is homicidality, if that's a word, or homicidal behavior similarly tied to mental ill health? Or is it possible that violent homicidal behavior is just an innate part of the human condition that exists just below this thin layer of, or veneer of civilization that we impose on people? What's your perspective on that?
Well, first I want to make a comment on the division of the 3 types of disorders. Many of the people who have very serious mental disorder have large periods of their life in which they are well, in which they can live and participate. They are great artists, they are great musicians, there are various things. Some of them are great dancers. Nijinsky comes to mind, and many others who have in fact, so one should not take this severe mental illness is not the condition which is always present for all people at all times. It is a disorder which today is amenable to very considerable amount of treatment, and many of the people have a long and good life without the disease. We have done a study in Switzerland over 60 years showing that the majority of the years of illness, properly treated people can live their life like anybody else. So that's just a comment on the severities. We should not think that these are hopeless cases. They are not hopeless, but sometimes they're given up, and that's not very helpful for them. Now, homicidality. First, we have to also recognize that mentally ill people commit fewer murders than normal people. And if you want a really homicidal group, take the army. They are shooting everybody down. Are they homicidal? Well, yes, they are. They are, in fact, going around shooting anybody whom they see. And I think that the notion of homicidality very often has to be understood a little bit differently. Some people are treated while they have a mental illness so badly that in the end they lose their nerve and will in fact react violently and maybe even kill somebody. But if once they do, it's the senselessness of the act which stresses people. It's all right if you kill somebody for a reason, but it's not all right if you just kill somebody. And I think that difference makes a big thing which makes the homicidality much more, or homicidal acts, much more visible and much more discussed in people who have mental illness and in people who do not have mental illness. So I think that we should, it is the fact that they are committing less crime than and less homicide than normal people is a fact that we should remember and keep in mind as you're discussing this.
Mm-hmm. Thank you very much, Norman. To continue on this a little bit and the connections that people are alleging here, in a recent U.S. vice presidential candidate debate, Vice President-elect J.D. Vance stated that mental health problems are more common in the United States than in other countries, and that's the reason why we experience more gun violence. Jay, do you believe that serious mental disorders are more common in the U.S. than in other countries, and that this explains the dramatically higher rates of U.S. gun violence and mass shootings than in other developed countries?
Yeah, I think Norman said it all when he pointed out that folks with mental illness and severe mental illness are actually much more likely to be victims of violent crimes than they are to be perpetrators. I think unfortunately, when a person with severe mental illness or mental illness does commit a crime, it kind of garners headlines that perhaps make it seem like it's more prevalent than it is. But as far as the gun issue, I don't think there is much evidence to suggest that mental illness is more common in the United States than any other country. I think it might be fair to say, because of our fragmented access to healthcare, that access to mental health care is more fragmented here than some other developed countries. And then look, as far as guns go, I think being as unpolitical as possible, just stating facts. I think the difference between us and other countries that don't experience mass shootings is we have a lot more guns. That's I think the main difference, and you can draw whatever conclusions from that difference that you want.
Yeah, fair enough. Gabby, do you think that there are factors that affect the prevalence of serious mental disorders? And in your experience, do you know if any of these disorders are more prevalent in other countries and cultures? So Santosh actually mentioned that there were some diagnoses that appear in patients in Asia that are not prevalent other places. But are you aware of evidence that the prevalence of these major disorders is greater in the United States or in other countries than we see in general across the world?
So thanks. Okay, so let me take schizophrenia as an example. Let's start with that. What does it tell us? Globally, it's the prevalence about 1 in 200. But actually, in the United States, it's actually in North America, it's 0.25%. When you compare that to Vietnam, it's 5%. So really, in terms of, if you take shared numbers, and percentages, actually it's not. Actually, it's better in the United States, than the rest, So I think let's start by saying that. But when you start, obviously, because you have more access to television, news, and so often we exaggerate events, so that it becomes as if it is, So that's in terms of that, But in terms of depression, anxiety, so there are many things that drive that, So for example, social isolation, poverty, those are things that contribute, loneliness, that contribute. And if you remember the work many years ago with Norman, we did together in DDD, diabetes, physical illness driving depression, and depression driving driving diabetes. So there are many issues, So really, when people present to us, the way we need to start looking at it, so perhaps think of a pathway. What is it that is making this individual be prone to this illness? And if they have the illness, what are we doing to treat them better and prevent people getting worse? And then rehabilitating them back in a loop way, so that we don't have this dichotomy that you are ill or you are not ill, and that's it. No, it's a spectrum. And when you think, I was looking at some people some time ago, in 2030, depression will be the highest cause of morbidity and disability worldwide, as individual illness. So really, what we're saying that we have to do something to prevent. And then, I've been in medicine for some time now. I'm thinking, right? The medication we use in mental illness, for mental illness, they're very toxic. And yet, there are no new medications coming, so there are no new investments, If, look at diabetes, many things have changed. Look at breast cancer, many things have changed. So really, I'm hoping that we can form a global alliance that will help us to put pressure on system. We need our government, we need citizens to work together so that we can tackle the cause and then also provide help and hope for the future. So I'm hope that's really kind of thing I'm looking at. So it's not just the prevalence, it's what are the things that leads to this illness, and how do you help somebody to recover? And then when they recover, employment back to work, how do you get them to go back to work? You know, how do you provide a housing instead of them living on the streets? In many parts of in developing countries, most people who are mentally ill end up in prison or in the street. You will never recover from that. So recovery is now possible under those conditions. So I think that's the way I see it, you know, from my own clinical practice and what I read in the literature.
Okay, great. Yeah. The last decades have seen a trend towards deinstitutionalization of the mentally ill, as Jay alluded to in his opening comments. Norman, so where are the seriously mentally ill to be found, and who's taking care of them?
Well, the institutionalization was a wonderful idea because some of these mental hospitals which we had before that have been really terrible places. I remember visiting the Pilgrim State Hospital, which was 13,000 beds at the time and 12,000 personnel. And it was a place where you entered and never came out again. And I think the notion of deinstitutionalizing were very good. But the preparation for this was not sufficient. So many of these people who were, after many years of being in a mental hospital, have been discharged into the community, didn't find anybody in the community who would look after them. And many of them, in fact, were finished in prison and were not deinstitutionalized, but trans-institutionalized from one institution into another one. And I think that was one of the problems. The other lot, which have not ended in other institutions, have been put into the care of carers. And the carers at present, I think, are the most neglected people that you can possibly imagine. These are people who have, for a life, taken on a duty to look after somebody else. Nobody is paying particular attention to them. They have significantly higher physical illness rates and mental illness rates. Many of them, in fact, are becoming depressed because it just takes so much to look for a lifetime. In fact, they are giving up their life in order to make the life of someone else livable. And I think they are the most admirable group. And we have many things that we could do to help them. Number one, we should pay them because they are saving money, which was previously spent for their treatment in hospital. Why not give 10% of that to a carer who is at home, who might then perhaps share the care with someone else whom he would hire or do something else with a little bit of extra money. In some places where this has been done, it works like a dream, where in fact the carers have been given a certain amount of money. The second thing that we should also give them a bit of respect. In Britain, once a year there is an announcement of the best carer family. It's not that one best carer is all that. There are many others who are just as good, but at least it's given visibility to the task which they are giving. We are never inviting them to come to medical school and teach medical students how to look after people at home because they know how to do it and we do not know. Not know as much unless we had an experience ourselves. In France, some time ago, there were teachers who were expecting that the medical student, before he is allowed to enter into psychiatry, must spend several days in a house, in a home, in which there is a person with a mental illness who is at home, to learn the multitude of tasks that have to be done to keep a person in good shape when he's at home. And I think that it's one of the great priorities for mental health care today is to think of ways in which we can help carers, pay them a little bit more, listen to them when they tell us what needs to be done, advise them, treat them for their illnesses and so forth. So I think they are really the heroes of our times.
Thank you, Norman. I know this is a topic that's really close to your heart, and raising awareness of caregivers and respect that they deserve. Perhaps creating opportunities to pay them or what have you. It's a huge issue, and I think in this country, whether it's child care or elder care or care for the mentally ill, we don't seem to have much of a workforce that's focused on that. Does anyone else want to weigh in on this, Jay? From your perspective, is this something that you're focused on here in the U.S.? Because it seems that we have a crisis in terms of identifying people that can be these caregivers. I mean, if you find one, I mean, they're are they trained? Are they compensated in any way? And not to be too political, but who are the people that end up doing this? And after we deport 12 million undocumented aliens from the U.S., will there be anyone left to fill these low-paying jobs? And not to be provocative, but you want to weigh in on this, Jay?
Yeah, I mean, Norman, everything he said was spot on in terms of family and loved one caregivers. I think mental illness is a family disease, right? And I always think about an analogy like the Ronald McDonald House, which is something in the United States, which understands that children with complex medical needs, their families need support that that could take place while they are getting the care they need. And I don't think that there's anything similar here, and there really should be. I think first of all, like care for the caregivers is really important. There's some states experimenting with things like caregiver tax credits, things of that nature. I think that should be explored further. And as far as workforce, like we could have there are entire conferences on workforce issues in mental health. I think that there's two dimensions probably worth talking about. Number one, I think is the simple truth that we have more demand for mental health care than we have capacity to provide it right now, and a big reason for that is lack of a adequately compensated workforce. And so I think money is definitely part of the solution. I think the other piece of it is the non-money aspect of it, which is I think we have an obligation to treat these folks like the heroes that they actually are. Like, for example, the Indianapolis Colts here, our National Football League team, recently started having mental health professionals day at one of their games, where just like veterans or other first responders, the mental health professionals get discounted tickets and they are able to attend the game and they are recognized on the field. And I think we have to do more to venerate this profession as like a truly sort of first responder, noble, dignified profession. And that's something that's underway but needs to be kind of doubled down.
Yeah, Gabby, you work with groups all over the world for the World Federation for Mental Health. Have you seen any programs there focused on caregivers that you think are worth mentioning?
Yes, thank you. So we have to look at caregivers, two, maybe three groups, so that's a simplistic way of looking at it. So one group are those who volunteer unpaid, and the other, of course, who perhaps are paid. So let me first of all focus on the unpaid volunteers, that we see even in my own practice in London. So young people caring for their parents, it's one group, and the disadvantage for them is a lot, so they may drop out of schools, they feel guilty going to school. They are, they lose their youth, they've not had time for that engagement. So that's one. Parents looking after their children is another group, so really, so it's a major sacrifice. So Norman, the rest are correct. They are the backbone of social care and also the backbone of all the things we do. So really, so we have to find a way to elevate the role and what they are doing. And the way to look about people who are paid carers, they are paid low job, low paid, so obviously they are disadvantaged also. So really, so we have a system that is not good for people who are paid or people who are not being paid. And within that, everybody is suffering. And when they were closing our salon many years ago in most part of the world, one of the things they were saying was that the money will follow the patient. But I don't think the money follow the patient, because if they follow the patient, they will have looked at how do you pay for these carers who support the patient, So I don't think there's any clear example where that is very obvious. So, but I know in England now what they're doing that they say carers should have annual assessment. So they go to their GP, will try to look at what their needs are, but it doesn't include financial. So really, so we need to think about innovative way of financing, carers, so that they can at least have dignity and self-worth. Think about respite care for carers, so they have, in some place or in some parts of the world, they have 1 week respite care or 2 weeks respite care, which is very good, we should celebrate it. But for the rest of the time, they are there 24/7. So if I go to work today, I finish work at 7 or 8 o'clock, I go home. So it's finished, but as a parent, you don't finish, isn't it? It's all the time. So really, so let's find other ways, of ensuring that perhaps we make a case to the United Nations. Maybe they need a global program for carers, to say they keep the system going. Economy will not survive without carers. Well, therefore, at the United Nations level, what can they come with some global policy that people can debate, and hopefully something concrete will come up from it, So really, so I believe in carers, in my own day-to-day practice. We see little example here and there of things happening, but they're not well funded, and therefore we're not getting the maximum benefit. I know there are some good cases in India where I've read in the past where carers do a lot, but are they recognized as part of the workforce? I don't think so. But if we recognize them as part of the workforce, then we will give it a value. So I think I will stop here first,
Okay, good. Thank you. So it's thought that early and intensive intervention of patients with schizophrenia can improve outcomes and facilitate recovery. For example, New York State has an intensive government-funded program called On Track New York. Jay, drawing on your experience as director of the Indiana Division of Mental Health and Addiction, have any early intervention programs been implemented here in Indiana, and have we seen any improved outcomes attributable to them?
So I'm going to take your question maybe in a little different direction. I have a lot of trouble sometimes talking about specific programs because the truth is, when you've seen one state or one community or one program, you've only seen that state or community or program. I mean, these things have to be designed with like the specific needs of the population community in mind. And so I think it's much more important to focus on systems that can support the programs as opposed to the programs themselves. And so, the example I'll use is in Indiana, we are on the at the very beginning of implementing a new way of paying for behavioral health care called Certified Community Behavioral Health Clinics, or CCBHC, which is a national program that pays for behavioral health care in a way that covers the actual costs of care, as opposed to having providers trying to duke it out in a fee-for-service model. And so systems like that actually address the infrastructure of the system, I think are what we need to focus on, because that is what's broken right now. And then once we do that, we can figure out what the evidence-based programs to intervene are. And then the other thing I'll say about prevention, right, which I know that wasn't exactly your question, but I think it's worth pointing out here is the best prevention are things like housing and food and social supports and the things that actually make life better and richer and worth living. And easier on people. I think, folks, when you talk about improved outcomes, the best intervention for somebody that is homeless because of untreated mental illness is housing, right? So it's not any particular, modality of treatment. It's just giving them a house. And I think that is something that we all need to take away, is that, yes, you need to solve for mental illness by not solving for mental illness, if that makes sense.
Okay, yeah. Santosh, you have a lot of experience in India and around the world as well. Any early intervention programs that you're aware of that have been making a difference there?
Well, most disorders and diseases, whether it's psychiatric disorders or medical diseases, they come very late for treatment. So when we see cancer, it's really in very advanced stage. Even if it is diabetes, people have had diabetes for a long time. The pathway to care to a modern medical system is really a very long pathway, and it actually takes away a lot of time. It's also probably related to the availability of many other systems of medicine, like the Ayurveda, the naturopathy, the homeopathy, and Unani. So there are many, these are scientific ones, which are, which have regular training programs, which is equivalent to the bachelor's degree for MBBS. But there are also traditional healers And there is a lot of, people going to faith healing, which causes delay. So the early intervention programs are, I mean, they are still in a very research mode or in a project mode, and in probably serving a very small proportion of persons who are actually having either mental illness or even physical illness. But that is something which needs to be looked at. But I also have another doubt about it's not a doubt, it's probably a controversy about this business about early intervention. When we see patients in an Indian clinic, those who have had psychosis, many of them have had psychotic episodes in the past, and they never took any treatment, and they recovered. And without any intervention, without any medication. Some of these might be related to drug use, cannabis use, or some other drug use, and some are related to stress-related things. So, the whole thing about early intervention it's something which we should, take with a pinch of salt, because once the intervention starts, as we know, and many of the disorders, they get almost lifelong medication, lifelong treatment. And as Norman was mentioning some time back, even people having serious illnesses, they have it for some time, and then they have another time when they are reasonably all right and living well. So it is something which one has to be very, very cautious about. Thank you.
Okay, good. Thanks, Santosh. Want to talk a little bit about the COVID-19 pandemic and the resulting lockdown. It seems to have triggered a number of behaviors, including various mental disorders. And Gabby, I wanted to ask you, since you see a wide range of patients from different cultures and so forth there in London, what did you see among your patient population during the pandemic, the COVID pandemic? And do you think this is a universal phenomenon, or were there social factors in certain places that increased or decreased the magnitude or severity of these disorders that resulted during and after the pandemic lockdown?
So the pandemic lockdown, was a very serious threat to both physical and mental health of the population as a whole. And really, it's one of those illnesses that actually have no respect, for whether you were rich or poor. So because once you had the rules, that were imposed on people, the fact that you can no longer make contact with others, and so really took away what I call the fabric of our society. So there were financial crisis for people. So many things happened. But the more vulnerable people they were, the more likely the consequences. So that was one of the things that struck us. First of all, let me go with the elderly population before, who were able, free to going out. They were now housebound. They became frail. They couldn't get support from their children, so they became lonely. So then women who had babies during COVID, the children, could not socialize. The early, the early 1 year of life was taken away from them. And what did we come up with? We'll come up with people now who probably, more sleep disorders are happening. People not having difficulty to adjust. PTSD, people lost loved ones, whether you like it or not, and even people in care homes, the way they died, who see anybody, so depression, general happiness, marriage breakdown, use of substances and alcohol. So it did not really have respect for, it wasn't to do with ethnicity or no. But when it came to issue of vaccination, was a different kettle of fish, for the COVID vaccine, that there were more hesitancy from those from ethnic minority for a variety of reasons. And perhaps again, so they probably suffered more towards the end, more illnesses where others were being protected, and therefore they, leading to other issues. So we are still suffering from seeing consequences of COVID-19. So I want to say that, so people have not recovered. People have become more frail. People are feeling fatigued from the illness itself, from the virus, so they say having that, so we are seeing more people than before. So that's one thing. And also, when you think about COVID-19 itself, suddenly mental health services stopped working for most people. They couldn't go to the center. Day center people used to go to stopped, So we have to prepare. I don't think we should say we've seen the end of COVID-19, there will be other epidemics that will come in the future. So what lessons have we learned? That's the first thing first. And how do mental services prepare for future, ensuring that we can use more telemedicine if it's necessary, and maybe getting permits, from the government to say, look, people should be provided safe place where they can go to. So that's the kind of thing that we are facing. We're seeing more people of anxiety, PTSD, OCD, many things. School avoidance is happening, and so much, so it's just a tsunami that we're trying to untangle. And I want to hear what other people are doing in other parts of the world. Is it the same, or England is different? I don't think so, but let me hear from our colleagues and other panel members what is happening and how they are managing to cope.
Yeah. Does anyone else want to weigh in on the way this might have affected different populations or cultures? Truly was a global disaster.
Thanks.
Norman, I might ask you, and welcome back. We see your photo again live. Do disasters necessarily trigger episodes of mental illness? And do we know what it is about COVID that seems to trigger these psychological effects in people?
Larry, Santosh raised his hand there. He was going to respond to you.
Oh, Santosh, please go ahead. Sorry.
Besides the disorders which Gabby mentioned, there was also a lot of health anxiety, and almost the OCDs became worse, and new OCDs started because of repeatedly washing hands and cleaning those, and a lot of people took resort to religion and spirituality in order to cope with it. There was fears. There was a lot of paranoia. It was a very strange paranoia that they will contract it from someone. And in India, it had become that people who were angry with anyone, with the administration or anybody, and they would go and spit in public, just out of frustration and as a way of protest. So there were a whole lot of other behaviors. We can't really call them as related to mental health or psychiatry, but these were behaviors which were noticed, and of course grief. So much of complicated, severe grief, because suddenly people were dying, and there was no place to, there were people were dying in hundreds in a locality. There was no place to bury them or to cremate them, and it was causing a whole lot of tension. So there's a whole lot of things. Talking about it is actually giving me a feeling of PTSD, to be reminded of that. Thank you.
Yeah. So Norman, about disasters, I know you've talked in the past about the behavior of people with mental illnesses during disasters. What are your thoughts here about disasters triggering mental illness?
Well, disasters are not lived in the same way by all people in the community. If you have an apartment of one room and one kitchen, and you have 6 children, and you have to spend 24 hours a day with them without being able to get out, it's a different experience from somebody who has a luxurious house and can live in it as he wants or she wants. So I think that one has to recognize that misery becomes even greater when there is a disaster happens. But many people are living at the limit of not breaking down, and when the disaster is added to the trouble which they have, they may in fact have breakdown. What we've also seen is that when a disaster breaks out, the group that is usually most neglected are people with mental illness, both in mental hospitals and elsewhere. In the Fukushima disaster, which we had, people were evacuated from the area that had been polluted, but the mental hospital was staying there. It was evacuated last because sort of not as a high priority as the scene. So many things happen of this type in disasters, which one has to keep in mind. Alcohol use, for example, goes up sharply. And these people are not alcoholics, but they drink. And while they're drinking quite a bit, they behave in ways that we are subsequently considering to have been very disordered. And one should also understand that there is a big difference between being depressed and having a depression. external circumstances may depress all of us, but that does not mean that we have a condition which is a depression, which is responding to a particular type of treatment and so forth. So that's another factor that has to be kept in mind when we speak about disaster. Many, if not all, people are depressed, but that doesn't mean that the incidence of depression has gone up. Some other things happen which we did not expect. Suicide rate in some countries went down instead of up. Canada, for example. We also saw that fathers have been reported that they, for the first time, they recognize that they have children because they never saw them before the disaster, before the pandemic. They were sort of going up in the morning into their work, coming back in the evening. The child was there, but the parents never, the father in particular, never saw them. And they spoke about it. It's a lovely paper that's been written about the experience of fathers for the first time, they recognizing that they have children of small age, which previously they didn't see. So I think disasters are very complicated developments, which we have to keep in mind when we are interpreting this.
Great. Thank you. I wanted to talk a little bit about isolation. And obviously it came around with the pandemic. We were forced to isolate. But as the trend towards spending more time alone isn't necessarily a new thing. But Norman, is there something about isolation that you think seems to increase episodes of mental disorders?
Well, loneliness is at present, and isolation, both of them. Loneliness being more the experience of being isolated, while isolation is the factual isolation from other people, has been recognized as one of the top problems that we are having. To the level that Japan, for example, is now created the Ministry of Loneliness, and South Korea is considering to do the same. I think that England, if I'm not wrong, is also considering a part of the ministry that will deal specifically with loneliness, because such a big problem that there. In some instances, there are three phenomena that I think are interesting. The first one, which is not recognized sufficiently, is that aging of the population is not gone as we previously expected it. We have thought that there are people in the normal age, and then there are sort of children, and then there are adults, and then there are old. But as it turns out, it's not so simple. There are children, all right, and then there are adults, and then the adults get retired. But when they retired previously, soon after their retirement, they died. But now they don't die straight away. They are living for 20 years after their retirement. The last 10 years of their retirement, they're old. But the first 10 years after retirement, they're not old. They're not young either. They're nobody. They don't know what to do with themselves. They have no jobs anymore. Nobody wants to employ them. They don't know. Nobody is. And so they go out of the house and they do all sorts of things. And I think that is a group that at present we have lost sight of. And this is a group that previously served, the group of 65 to 75 served tremendously by being at home and receiving the children when parents were doing something, etc. But this 65 to 75 group is no longer at home. They are out there, somewhere doing something else. And I think that one has to recognize the structure of the population has significantly changed by having these 5 groups now, the very old, the group of 65, 75, which are not sufficiently old to be counted as old and not sufficiently young to be employed. Then there's the group of adults, then there's the group of adolescents, and then there's the group of children. And I think these groups have not been sufficiently examined for what they have to do with mental health. Mm-hmm. But there are interesting things which have developed. For example, in Denmark, they have, because people are very often lonely. How often? Well, maybe some figures that have been reported, they are approximately, in Japan, approximately 1/10 of all people who die have not seen anybody for a year before their death. So they're discovered in their home as dead a year after they've died. And that's 10 to 15% of it. And others are several months after they have died are being discovered because there is nobody coming to see them. Nobody is there. They have no contact, nothing. On the positive side, some countries have done nice things. For example, Denmark has decided that it will try to make sure that if there is nobody who looks after the old people, they'll use technology. So what they have done is they have a mat which they put in front of the toilet. And the mat is a signal thing. So if the person does not enter doesn't touch the mat for more than 8 hours, there is a signal that rings in the health station. And they come to see what is happening with this person who is no longer going to a toilet. And I think that the toilet map that has been produced in Denmark is a beautiful example of a use of technology to help people who are very lonely or who are very much alone. And another one was in Holland, where they have created a change in the life of social workers. Previously, social workers in this particular territory have been sitting in the hospital or next to the station, and they were receiving people who gave them advice, helped them to overcome their loneliness, and helped them in various ways. But then they did a change. They said, no more sitting in the office. Here is a list of 20 people or 15 people. These are 15 families, which are your families. You have to go to them once at least, if not twice a week. You must sit with them. You must help them to live better. These are people who have somebody who is sick, who are not maybe well educated, not very well connected, etc. So this social worker became a very knowledgeable son, extra son in the family, who looked after all the needs that this family had. And he was there regularly, coming every several days. He would come and help everybody to live in a complicated world in which there was somebody sick and somebody was very lonely, etc. But that changed completely the nature of the social workers' activity. So they thought that nobody will like it. So they asked the social workers. They were delighted. For the first time, they said they felt there is a purpose to their life, because they are helping these 15 families have become their families. They received them, embraced them, they spoke to each other about everything, and they were spending their day, every day visiting 4, 5, 6, 7 families, and doing this every day throughout the time. Never again they're putting their foot into the hospital in which they previously worked. So I think that there are changes which in the service style and in the technology that have been helping people who are lonely and service. There's one thing I want to mention, and that is we have put a lot of emphasis on technology, telemedicine and telecommunication, etc. But forgetting a little bit that that's not really the answer for many elderly who do not know how to use technology and who are very difficult to learn how to use computers and make advance of all the different tools that they have.
Excellent. I think you focused on two themes, and I think we want to kind of wrap up around those two themes. One is continuing to discuss a little bit this epidemic of loneliness and isolation, and then secondly, to jump to social media, and then we'll open it up to some questions and some other things in case we have time. But we want to make sure we stay on schedule. So I would say that I think. Jay mentioned the Atlantic magazine's latest cover story called The Anti-Social Century, which illuminates America's loneliness epidemic. And part of an American time use survey has said that socializing in person in the United States has dropped 20% between 2003 and 2023. And among people younger than 25, it plummeted more than 35%. So I want to focus a little bit more on this issue of loneliness and then jump to social media, because as Norman has said and Santosh has commented earlier, there could be some ways to address it, but also social media could be causing some of the issues. So let's focus on those for a little bit, and then we'll open this up. So Gabby, can you say that this epidemic of loneliness, as you interact with people with different mental health groups all over the world, are you seeing this as a universal phenomenon, or is it and does loneliness trigger episodes of mental disorders, and are some cultures more immune to that? What's your experience?
First of all, loneliness and connection, to be connected, is a global phenomenon that people want to connect. So if you start from that perspective, then the opposite, loneliness, becomes an issue. So, as Norma already described, so people are getting older and their children have emigrated, and so previously people have lived together in the same household and probably will not notice it. But now it's different. So things are changing, sociological changes. So therefore, people feel more lonely. Night times are very difficult. You know, people cannot finance even heating and cold. So really, so people are presenting to us either too late or, you know, or just say they can't cope. You know, so really, so we, for example, in our practice now, and many parts in England, they have what's called social prescriber. That's, you know, they're being paid by the government to go to people to see how they can, you know, bring them into the society, taking them to centers and co. We have care coordinators that try to coordinate. And then, so we run special frailty clinic to be able to look at our older adults and try to find something. But when you speak to people, you know, people, they feel very sad, being lonely, you know, and really you can understand what it is, you know. And these are people who were very strong in the past, you know, who walked all over the world, and suddenly you are on your own, you know. And one patient I saw some time ago, she said, it's as if you don't exist. That's, you know, that's how she described it, you know, as if you don't exist. So really, for you to have done so much and suddenly feel you no longer exist, you know, it's a terrible thing. So really, so I think we must highlight the issue, you know, one of the things I also want us to think about, one day we'll be old too. So really, so, you know, if, you know, we need to start thinking about a system that will be good for us. And also, so maybe this is a selfish aspect of it, but I think we need to consider it in a different way. You know, that's definitely my thoughts on this.
Yeah. Yeah. Jay, is there anything in Indiana that you think that you've worked on or have thought about policy related to addressing the loneliness, phenomenon of loneliness?
Yeah, I'll say two things. I think number one, I think loneliness is a direct offshoot of the decline of some institutions, you know, including, for example, religious institutions. I think there used to be you know, again, when churches were, again, I say this as somebody who is not religious, but I think when churches who were a lot more prominent part of public life, you could continuously, frequently, predictably expect to have random encounters with your neighbors, which is something that we don't have as much anymore, just because of that reason. And then the other one, which is related, is the built environment. I think you look at, for example, Carmel, Indiana, which is a town that, you know, we're familiar with. You know, they invested a lot of public money into public spaces. And you go to downtown Carmel now, which used to be a sleepy suburb where people are isolated. You go to downtown Carmel now, and any hour, any time of day, you see people interacting because there are spaces for them to do so. So I think that the notion of the built environment promoting social connectedness is one that we actually have some impact on, that we need to make sure we're incorporating, and then also making sure that some of our institutions are healthier than they are currently.
Okay, good. Thank you, Jay. Let's talk a little bit now about digital media before we open this up, and social media and its impact on mental health. Santosh, I know you've looked at this problem pretty extensively. What have you seen as the problematic effects of the proliferation of digital media, especially among the young? And what, if anything, is being done to address this?
Well, Larry, before that, if you permit me to make a comment about this discussion about loneliness. Now, loneliness is a problem only if it troubles the person, because spiritually speaking, people seek solitude. You know, becoming lonely with solitude is actually, they have transcended. Half the problems are in the world are because of people. You know, when they live with people, there are problems because they each makes a demand on each other, and there are expectations on each other. You know, that's why we have songs like "You Just Leave Me Alone." You know, so you remember Michael Jackson saying, "Just leave me alone." So, you know, people say, "I want my space. I want my space. You give me space. I want to be alone." So, I mean, it is a problem. I mean, I think it's a more like a global knee-jerk reaction about, you know, panicking about loneliness. But one has to look at it in the right perspective about whether it is distressing for the person, whether it is harmful for the person, or whether it is for the good of the person. Norman wants to say something, Larry.
Mm-hmm. Yeah.
Yeah, no, just to say that undoubtedly what Santosh says is perfectly true. But I think that there is a difference between feeling lonely and being isolated. And I think we are worried in particular for health reasons about both of those, because being isolated means that you don't care when you need it. You don't feel lonely, but you are alone, and somebody should look after you. On the other hand, there are people who feel very lonely, even though they are surrounded by other people, because that's more of a psychological state in which they are. And I think that both should be considered. The one on isolation has been now reflected in laws. China, for example, now has a law which will punish children very strictly if they have not looked after their parents. And even in a country like Bangladesh, a similar law has just been passed. That's dealing with isolation and leaving people alone, although they have children or somebody else who should be giving them some support.
Well, to continue with that, Norman, even in India, there is a law now that children have to look after their, elderly in the family. Like, coming to the issue about social media and digital media, Larry, which you asked, I was just reading that from 2025, after the Gen X, Gen Y, Gen Generation G, and Gen Alpha and Beta, from 2025, it is the Gen Digital. From 1st January, the digital generation has started. All the children born in 2025 onward will be considered as those born in the digital era. Where with all technology around them. The issue about digital media, I mean, reflecting on things which we have seen, when the pandemic came, in many media programs, I would say that social media is the new social support. When people could not meet people, it was the social media which made people connect. And schools were online, work was online, it was work from home and many other things. So it was, and it was the use of technology. And once the pandemic is gone, we have started complaining about the same thing, saying that, there is too much of screen time, too much of use of digital media and all. In clinical practice, actually, we were talking earlier about disorders and psychopathology. Now we see psychopathology related to Instagram, psychopathology related to Facebook. People say, I put a picture and I got only 10 likes. So-and-so has got 1,000 likes. And, so-and-so has made an adverse comment. So-and-so has made a good comment. So that is something which is causing anxiety to them. It's like it's the equivalent of the body dysmorphic disorder, equivalent to that. So it's going to be, the social media dysmorphic disorder that people are having. If they don't have enough friends, if somebody blocks them, I mean, people are becoming paranoid with that. And now now the scams have come up. There are fake Facebook accounts, fake. So a new type of paranoia is going to start. So social media is, I mean, it's a necessary evil. We have to probably, learn about it, get used to it, live with it. It's like once upon a time, there were no vehicles. So then the cycle came, the motorcycle came, the vehicles came, then the fast vehicles came, and then there are also accidents. People are dying on the roads. These vehicles are killing them. So it's the same way. I think in the same example, one can look at social media, how it is developing and how it is going to cause more and more problems. But we have to look at more the advantages, how to use it, for mental health and for prevention of mental health problems, or even for the long-term management of mental health issues. Norman had already mentioned about tele mental health and its limitations, especially for the elderly.
Mm-hmm. Santosh, have any of the diagnostic manuals yet, either ICD from the WHO or the US's DSM, have they identified, articulated?
Larry, these came just before the pandemic. The ICD-11, though it was started and I think finalized by 2012, it got released only in 2019 or 2020, and the DSM-5 was finalized by 2015. So the pandemic came after that, and but your point is well made that probably there should be certain categories related to that which should be included.
Okay. Before we go on, I want to maybe give people a chance to wrap up, give the panel a chance to wrap things up by asking, if money weren't an issue, and you were able to take that global mental health moonshot that we mentioned in the title of the program, that is, do whatever needs to be done to improve things. What would you do to improve the lives of people with mental illness? Maybe start with Gabby. Can you say something?
Yes, I think, one of the things I think we should be aiming for is for mental health, mental illness to be respected, just like to be looked at, just like other physical illness. And to look at the social determinants of health. If we can invest in social determinants of health, good housing, education, that really would be the kind of thing. And I'm hoping that we could actually have a global consensus on what we need to do, minimum that we need to do across all culture and nations, whether you are rich or poor. If we can do that, at least, we will have helped the majority of the people of the world.
Yeah, thank you. Santosh, what would you do to launch the mental health moonshot? Santosh?
Sorry. Yeah. I think, Norman is an expert in talking about stigma and about mental illness. But I haven't seen him talk much about the stigma which the psychiatrists and mental health professionals themselves have. And it's time that in the current era, mental health professionals should feel that, they are an important part, and they should also have their own role in destigmatizing mental illness. I work in a small village and town, and I'm quite surprised that sometimes people just see that I'm a psychiatrist, and they say, well, even if they have come with a gynecological or an orthopedic problem, they say, can I see this doctor also? So the stigma is going away. So one should be probably much more open and talk about mental health problems, and especially politicians. I admire the American politicians because they come out openly about their mental health problems within themselves and their families. It doesn't happen in many other parts of the world, And I think a very important step of destigmatizing can be if celebrities and if politicians come up and talk about the mental health issues in their family, and general public would feel, well, it's just one of those things. It's just like diabetes and hypertension and arthritis and all that, one could have mental health problems.
Yeah, thank you. Yeah, Norman, what would you do?
If I have enough money to do things, I think my focus would be on areas that are now insufficiently regarded. One, I think that we have forgotten how to educate our children. Children are brought up with practically no contact with their parents. They are brought up with machines. They spend 80% of their time looking at computers and stuff. We should think of ways in which we can ensure that the child, when it's born, is in fact given an opportunity to grow up with their parents, to learn how to socialize, to learn ways of living in society. From example, and equally so, we should invest into schooling, because the schools have also in many countries have gone now with very incompetent teachers, with a huge amount of violence among children, with things that are happening sometimes at the extreme, where people shoot other school children in school. But even without that, the schooling, for example, in a country like Finland, has been completely changed. There are 4 days per week of schooling, and the rest of the time they have to spend with their parents and with their friends and colleagues, and not with their computers. And I think that we have to think a little bit of paying teachers better so as to attract the best people and give them a chance to be respected. So my one priority would be the children. The second priority, I think, which I would invest a lot of money, would be carers, which we mentioned earlier, which would make the carers supported sufficiently to look after people. And I think that there's areas of stigma, which Santosh mentioned, would be another area which I would like to invest. I'm not so very worried about the technology for treatment of mental illness. I think it's not too bad. What we would have to do, however, we would have to change the education of doctors in general to become more aware and more receptive of people treating people with mental illness. Gabi is a rare example of somebody who is quite happy to deal both in the mental illness and in physical illness. But many of the other doctors who are educated are in fact shying away from psychiatry, from mental disorders, specializing into ever smaller disciplines which have nothing to do with the mental state of the patients whom they're treating. So those are my 4 priorities. I would say carers, children, better education, different education, and stigma.
Thank you. Yeah. In Indiana, Jay, you've come out of a state job where you've thought about policy and implementation, and now I think your day job is to think about what we can do as a society to improve mental health care, and the job at the institute there. What would you say we need to do? What are your thoughts so far on this topic?
Sure. I mean, I don't believe in magic wands, but I think I think we've got misaligned friction kind of across the board, right? Things that are too easy, or things that should be easy are hard, and things that are hard should be easy, right? So it's really hard for people dealing with mental health care to access mental health care. I get calls all the time as the ostensible expert here, help me find a therapist, and I am not really any better than the person asking me in terms of helping them get care. So I think that we've got that friction on that end. Is there's way too much friction. Access to care needs to be much more seamless. I think that there is some promising progress on this. I think technology can help, but I think seamless access to care in terms of what needs to be easier. And then, I think that, instant gratification. I think there's a level of kind of a pretty destructive easiness that came out of the pandemic. I think of things like DoorDash and where sort of we just expect other people to make things happen for us in ways that are easy and demanded. And I think that there's some of those things might need to become harder, right? Because I think as humans, we do need more friction sometimes is good too. So that's my really pretentious way of answering that question.
Okay, well, good. There's a little bit of time for some Q&A. Let me point out, first of all, if you'd like to ask a question, send me a note in the chat box. Just say, I'd like to ask a question, and we'll open the mic, or you can open your microphone and speak. Second, I'd like to notice if you open your chat that Brianna Metzuk, who is at the University of Michigan, recently published a paper on suicide during the first year of the pandemic, and she wanted to share that with folks if they want to take a look at that. You'll find that in the chat. Do we have any questions or comments from the group? We have a wide-ranging group here with a lot of interest. Let me know if you have a question. And to Jay's comment about the DoorDash and so forth, I was just reading that that whole restaurant business is changing. That I read that 70% of restaurant dinners are now takeout or delivery. People aren't eating as a group, as a family, or as a group of friends in restaurants as much as they used to, which is really strange. And I don't see any questions coming through yet, but I want to note that Time Magazine just wrote an article. They talk about the need for a third place or a third life. That is, we have our work, we have our home life, but there needs to be a place where people gather outside of work and outside of home, where you actually meet real people for leisure and companionship. And just to put in a plug for Council on World Affairs, is that that can be a third place. That we all have an interest in international affairs, and that's why we joined this kind of an organization. And finding a place where you can meet with people. And I know that they're going to go back to in-person meetings next year. So if you're thinking about wanting to find a place where you can interact with folks who have common interest, think about joining the Council on World Affairs. And for those who don't live in the Indianapolis area, well, virtual communication is not quite as good, but this kind of an interaction can create some communication until you find your own happy place, where your own third place, that is, where you can interact with folks in in a public setting that's outside of home and work. It's good for you. And
I have a question, Larry.
yeah, Ray.
What is the role of drugs versus therapy in terms of addressing kind of mental health problems around the world? Or are we moving more towards drugs, or is therapy a better solution to some of these issues?
Well,
If
if I may answer that, well, the easiest thing for a psychiatrist to do is to prescribe a drug. It doesn't take a long time to do that, and send the person away and do that. In clinical practice, there are certain disorders which respond only to therapy or intervention, like the dissociations or the depressions or anxiety, some of them. And there are others which need medication, like, for example, schizophrenia, bipolar disorder. And there are some which require both, for example, obsessive compulsive disorder. The outcome is best if both an intervention, psychotherapeutic, as well as psychopharmacological medications are given. There is a shortage of people who can do therapy, and therapy is very time consuming. In many parts of the world, like in India, therapy is not given much value by clients or patients. They say, hey, you're not doing anything. You're just sitting and listening and talking or giving advice, whereas another person is writing a medication and getting it from the pharmacy. So the acceptance of therapy is still a way behind.
Mm-hmm. Before we turn it back to you, Ray, I want to give everyone who signed in a chance to take something away, and our panelists can bill us for taking time to answer this final question. But would you suggest something that we can all do to maintain or improve our own mental health and well-being in this new year? Does anybody have something to offer us?
I will just share I've been very skeptical about this for a long time, but I just started journaling every morning, just writing whatever comes to mind, usually gibberish, but I've found it just kind of clears all of the nonsense out of my brain and helps me think better. So, and gives me perspective sometimes on things in my life. So if you don't do that and you've thought about it, I was very skeptical and resisted it for many years, but I found it to be, and it's been 15 days. So, but I would highly recommend.
Norman, do you have something to offer us?
For everybody, yes. I think that they should put their telephone into a cupboard for 6 hours a day and try to speak to people around them and to everybody whom they see. And they should smile at people occasionally, and they should wait for people to smile at them. And I think that I have one colleague who does not have a mobile phone. He's a very important man. And he says, well, why should I have a mobile phone? When I'm at work, they can get me through my telephone at work. When I'm at home, I have a telephone number. My friends have my number. But in between, why should I be disturbed by anybody anytime? So now they have been convincing him that he should use the telephone more or less like an Encyclopedia Britannica, so that he can look up the various kings of England at any time he wants to do so. But basically, he has said, I refuse to be separated from people by technology. I would like to see whether I can come back into society with people. So one advice I would suggest is maybe a few hours obligatory being with other people, being with them and doing whatever you feel is of common interest.
Great. Gabby, do you have something to offer?
I think friendship is what I really think about, having friends, having, contact with people to stimulate your mind and brain, having a mentor, look for a mentor for yourself, who can provide you guidance. I think really friendship is the thing, And really, I remember when we started Wonka, we used to say, join Wonka and make friends and see the world. And I think it's about that, So really, I will encourage people to make friends, and also even friends at home, it's also good to have, So that would be it. Friendship is the thing I would suggest.
Yeah, and you have a lot of friends, Gabby, I know.
Yes.
I consider you one of mine. Santosh, a final comment from you?
Well, I have two phones. I'm sitting with two phones. I have the fear of missing out. When while others were talking, I have responded to whatever emails and messages that I've got. So I can now it's almost midnight, so I can sleep in a very relaxed way. Well, the point I'm trying to make is that we have to adapt to the things which are coming and which are going to come, and many of those we still don't know. Now the whole thing about AI and machine learning it's going to give us another shock, and some of us might not be so cognitively great in being able to accept that, and it's going to be difficult. But that is how if we want to have connections with our children and grandchildren, we should we should learn what they are doing instead of expecting them to learn what we know and what they would like us to do. So the mental health is going to be very, very exciting, and with the new inventions and discoveries and advancements in technology. So I just wish everyone all the best. Thank you.
Thank you. Yeah, we're getting to the bottom of the hour, and a couple of questions have come in, but I want to respect the fact that we said we would hold it to an hour and a half here. So I want to thank everybody for participating. Not only our group have come to us from all over the world, but our panel of experts that have shared their experience with us and their time. And I want to thank Norman Sartorius in Geneva, Santosh Chaturvedi in Bangalore, Gabby of Bajaro in London, and Jay Chaturvedi here in Indianapolis. Thanks so much for sharing your insights with us. And Ray, I want to turn it back to you, and thanks for letting me give me the privilege of hosting this program.
All right. Well, thank you very much, Larry, and thank you to our panel for a very stimulating discussion today. I think the takeaway for me has been the commonality of some of these issues. That we tend to think different countries may have different needs in terms of mental health and so forth.
Thank you very much. Yeah, for the change, interchange.
Yeah, thank you. So with that, I just wanted to thank everyone on behalf of the Indiana Council on World Affairs, and also just remind those of you who are members and may be interested in becoming a member. If you go to our website, you can join the organization, and you will be receiving information shortly about the Great Decisions program. With that, thank you all very much, and have a good evening, morning, afternoon. Depends.
Thank you very much.
Bye.
Bye.
Great to see your faces. Bye now.
Yeah, thank you. Bye.
Nice job.
Bye, baby. Bye, babies.
This is why I have. Yes.
Yeah. Are they twins? Are they twins?
No, this is a cousins. She is 2. She's 2.5.
Okay.
But I have 5 grandkids every day.
Lucky you.
Wonderful.
And very good friends with Mr. Samino.
Yeah, you're one of those people that Norman talked about, but you've given your time to take care of the little ones as opposed to wandering the world, like so many in that.
That's still in my goal, but
yeah.
Bye.
Thanks again to everybody, and good to see some faces that I haven't seen for a long time.
Yeah,
Thanks for joining.
That's the same.
Say bye.
Bye.
Wait, goodbye.
Bye.
All right. Now we have to go pick up James. Nice to see you. Very nice. Thank you.
Norman, Gabby, good to see you, and thanks again for your time. This was
Yeah,
very,
no, thanks a lot. I've enjoyed it.
Hey,
Yeah.
Robert, Robert, you had a lot of comments here today. I was enjoying reading your discussion. Are you a practitioner of mental health? You're
You have to
muted,
unmute.
Robert. You're muted, Robert.
You still have to unmute.
Maybe I can unmute him.
All right. Thank you very much.
Bye.
Thanks, Norman.
Talk
Thank
to
you,
later.
Gab.
Bye-bye.
Not a practitioner, but work with you on mental health. If you could hear me.
No.
Yes.
Located. Are you here in Indy?
And general semantics in Charlotte, North Carolina. And general semantics is in New York City as well as in India, actually international. And Albert Ellis is a New York City based. They would work with you also. And I'd worked with previously Randy Weingarten of the teachers, now president of the Teachers Union and Columbia University. Their various departments of education and mental health, etc. And don't we need better societies, working with the United Nations Association of America as well, and a supporter of your work and healthier societies, local to global, which general semantics is in it. The idea of interconnected NICS, which ties into your work also in the World Health Organization. And they do some good things with professors today of communications and multicultural education. They have an International Society of General Semantics online also today. Do some things which are different. It's a different type of thinking, which is based upon science and sanity also. So it tends to tie into your works, but what do the words mean? What do our lives mean? And how can we work together more constructively, which are things I'd worked with, which New York City and Interfaith, as well as other interfaiths on Martin Luther King, coalitions of mutual respect, which I add should be considered part of intergenerational, and the need for better community building was something we did in Charlotte also, and didn't go through because the focus on testing, then COVID hit, I guess, also. But the idea of Dinter Smith, what should education be, was a question in modern times, and how can we, which ties into Steinberg's whole child development, and you could add whole community development, and the need for better solutions, which are things I had worked on with the UN on world spirituality for the new millennium and 21st century leadership for better societies and cultures, actually, not just better United Nations, but how can we work together more constructively, and where do we focus? How do we develop more constructive engagement for greater success, individuals, families, and communities online in time rather than too late, which is the way we seem to be going since you're part of the world affairs also. But there's certainly pressing issues, and LJ Stambuk is a good president in Charlotte. Unfortunately, has some health problems, which also make it even more difficult. But I'm still alive. The UN is still alive. We're still alive, and good things can happen. So we need to be more appreciative and grateful. And thank you for your good works and the works of Indiana, which is an outstanding chapter. Also, the great decisions. I'd worked with actually this Westchester chapter, the United Nations Association, had people there who were founders with Eleanor Roosevelt. She worked with Eleanor Roosevelt on universal human rights. What do the words mean? And how do we ever get this accepted? She said the conservatives hid into political issues, but Her husband helped write the charter in San Francisco. And there was another gentleman who worked with other business executives to engage the isolationists at the time, who had rejected the League of Nations to the importance of socioeconomic upward mobility and stability building, and the politics and I believe mental health of ego and nationalism and identities. Actually, I was just on YouTube with, I wasn't with, but I was listening to Fareed Zakaria's book. He did talk about identities, which I've been saying. General